Hello, look at this question asked here for 10 marks, bronchogenic carcinoma. So they are asking about bronchogenic carcinoma, guys, for 10 marks. So look at this in lung cancer. What you say, bronchogenic carcinoma. This is of bronchial origin. Most lung cancers will be this only. Okay. Otherwise, what will you see in lung? The cancer from other parts of the body spreading to the lung. Okay. So here we are talking about lung cancer, bronchogenic carcinoma. Okay, so that means it is originating somewhere in the bronchus. Okay, now why are they asking this question in the exam, guys? Focus here. Unfortunately, this has become a leading cause of mortality. Its incidence is increasing. Okay, lung cancer incidence is increasing, and in women it is increasing. Okay, and the prognosis of lung cancer is poor. So all these things combined, they're asking you lung cancer in the exam. Okay, what is the first thing they have asked you in this question? Etiology. Okay, etiology means what? Causes. Why does lung cancer happen? Okay, so look at the cause. In this you can divide things as modifiable risk factors and non-modifiable risk factors. Modifiable, possibly you can stop smoking, exposure to chemicals, occupational hazard could be arsenic, asbestos, air pollution. You can control to some extent air pollution, I feel. Radiation exposure, lung disease also, if you have, you can get it treated, etc. Coming to non-modifiable, your age you can't modify, genetics you can't modify, if your family history has this. So this you will write as cause. Okay, so next they are asking about clinical features. Okay, clinical features of bronchogenic carcinoma. Okay, that we will just simply call it as lung cancer. Okay, so what will be the clinical features if you have lung cancer? Think about it. Clinical features: cough, yes, you will cough a lot, very good. Short of breath, dyspnea, very good. Difficulty breathing, very good. Dyspnea. Then, so overall, if we talk about the history of this person, no, he'll have some unexplained weight loss, could be, and then he'll have fever, possibly. His history also, if you ask, no, tobacco exposure or some occupational exposure to asbestos, radon, diesel exhaust, metals, etc. Okay, hemoptysis means sputum having blood. Okay, this is something you have to remember. So these are some clinical features that, along with history. Otherwise, you will say signs with symptoms: cough, hemoptysis, bronchial obstruction, breathlessness, pain. Some could be there. Some mediastinal spread can cause some clinical features like to the esophagus. If it is there, then there could be dysphagia. It's difficult to swallow for them, right? If the heart is involved, then some arrhythmia, pericardial effusion, etc. Superior vena cava obstruction, etc. All that will come in mediastinal spread. Okay, then so many things are there, guys. Let's go to metastatic spread. That is, metastatic spread means it's a cancer. It can spread to every part of the body and cause a lot of problems based on where it spreads to. Okay, so we will not go into that. It can spread to anywhere, and it can cause anything. So that is what you have to look at. Okay, finger clubbing, this is very standard things. You would have seen the nail, right? The nail curvature and etc. So that's finger clubbing. Hypertrophic pulmonary osteoarthropathy. So basically the bones and the joints are getting affected, right? Again, there can be pain. Okay. HPOA, that is hypertrophic pulmonary osteoarthropathy. See, pulmonary osteoarthropathy. This is like so confusing, right? Osteoarthropathy, pulmonary. Okay, because the cause is lung cancer. Okay, then non-metastatic extra pulmonary effects. That is because of this lung cancer. It's not because of metastasis, but because of this lung cancer sitting in the lung. What else can happen? So that also you should know. What are those things? Let's look at them. Non-metastatic extrapulmonary manifestations of lung cancer. Endocrine, that means some hormones can get produced. Okay, inappropriate ADH secretion can happen, causing hyponatremia. So the sodium levels go down. Okay, then ectopic adenocorticotropic hormone secretion. Adenocorticotropic hormone secretion. Okay, hypercalcemia, calcium going high, guys. Due to why is this? Secretion of parathyroid hormone related peptides. Carcinoid syndrome, gynecomastia. Okay, the breasts getting more glandular, especially men. That's what you're talking about. Neurological problems, polyneuropathy, everywhere the nerves are paining. Myelopathy, muscles are paining. Cerebellar degeneration, wow, the brain getting affected. Myasthenia. Lambert-Eaton syndrome. muscles getting affected. Then clubbing, we told you, the finger digital clubbing. Hypertrophic pulmonary osteoarthropathy, we told you. Nephrotic syndrome, polymyositis. So the kidney is affecting here. Nephrotic syndrome, guys, focus. Polymyositis, dermatomyositis, something to do with muscle only, right? Myositis, eosinophilia. Okay, so these are some non-metastatic extrapulmonary manifestations of lung cancer. So many things we told you, Papa. Okay, now you try to take a deep breath. Let's continue. So one thing, if they ask you which hormones are produced because of lung cancer, if it is a non-small cell lung cancer, you can have hypercalcemia. If it is small cell lung cancer, you can have hyponatremia. Sodium will decrease. Okay, that is because of these hormones. Okay, some vasopressin ADH will get secreted, and because of which it will lead to hyponatremia in small cell lung cancer. So this reminds me that we have not covered the types of bronchogenic carcinoma. Let's look at that now. Great, guys. So the types of lung cancer, bronchogenic carcinoma. See, here in this X-ray, they are showing you some kind of a lung cancer here, and that cavitated. It looks like a cavity. Yeah. So you see here you have the primary bronchus, all that you know, right? Let's draw it. That will get divided like this, and then like this, and then something like this. All this you should know, right? So basically, adenocarcinoma means somewhere here. Okay, terminal bronchioles, mucus glands. Okay, or from the epithelial cells. It can be. So adenocarcinoma is maximum number of cases adenocarcinoma. So terminal bronchioles, and terminally when it is there, no, people don't realize very early on. That's what they are saying. Okay, this is maximum number of the cases adenocarcinoma. Then you have something very old one, adenocarcinoma in situ, which was also called as bronchoalveolar cell carcinoma before. Okay, again alveoli, terminal, you can remember. Okay, now let us go to the next one, squamous cell carcinoma. It's from the bronchial epithelium. So here you have the bronchia, bronchus, and you have the bronchiole and all that. Somewhere here you have the epithelium, right? That squamous cell carcinoma will be there somewhere here. Okay. So these things will show very quickly, because I told you peripheral means it will not show fast. If it is somewhere here, then you should be able to detect this. I mean, the symptoms will appear faster. Squamous cell carcinoma. You finished what and all? What is that? Adenocarcinoma. Then now squamous cell carcinoma over. Okay. Then based on the incidence, I'm telling you, then what comes is based on the incidence, small cell carcinoma. This is from neuroendocrine cells. Okay. This is one is from neuroendocrine cells. Okay. So they have some glandular function, some hormonal function also. That is why I think it is producing that hormone and all, which you saw now, vasopressin. Okay. So these cancers, 13% of the cases, and the thing why we have put it as red, small cell carcinoma, these are aggressive. Okay, by the time you detect, like, it will be very fast spreading, and that's why they don't recommend surgery in this. Okay, why is it called small cell? Because the cancer cells are looking very small in the microscope. That's all, compared to the normal cells. That's all. Okay, then you have large cell carcinoma, which is a very, very small percentage anyways. So what and all you have to remember here, guys. Okay, I will tell you. See, you have in this blue, no, whatever you have, adenocarcinoma, squamous cell carcinoma, large cell carcinoma, this we'll all call this as non-small cell lung cancer. What are all these? Non-small cell lung cancer. Okay, only this one is called a small cell lung cancer, SCLC. Okay, this SCLC is aggressive. The cells are small. They are from neuroendocrine origin, right? All that you understood. They are considered separate and given separate type of treatment because they are aggressive. Did you understand? That's all. So you have two types here: non-small cell lung cancer versus small cell lung cancer. Okay. Now let's go back and see how the clinical features were different. Non-small cell lung cancer can cause hypercalcemia, more calcium, because of some parathyroid and all that, they said that, right? And small cell lung cancer, which we will use red here, small cell lung cancer, hyponatremia, because it is producing some hormone, vasopressin, anti-diuretic hormone, right? And because of which there will be hyponatremia. Okay. Investigations and treatment. Let us look at it very overall. Investigations. Imaging, you will do standard X-ray, CT, right? All this you will do. So let us see in imaging what they are saying. You might be detecting some pleural effusion. You might see some lobar collapse, lesion, effusion. malignant, some rib destruction you can see, hilar enlargement, opacities. What else would you see, guys? Paratracheal lymphadenopathy, raised hemidiaphragm. So many things you write, okay? Then you can do a CT guided biopsy. You can take a biopsy of the lung. This is the bronchoscopy they have done and shown the image here. Bronchoscopy also, if they want, they will take some biopsy tissue. Okay, then coming to the main, see, there is by clinical, all this itself you can do some staging, etc. But pathologically, if you're taking biopsy and observing under the microscope, then definitely you can do a histopathology, and that will be a pathological staging of the cancer. We'll come to that based on the cell microscopy, right? Okay. See, if it is somewhere proximal, you can still take a biopsy, but if it is very terminal, you can't take biopsy and all, right? That time you'll have to do surgery and then take the pathological sample. Sorry, you'll have to take the biopsy sample and then you have to do the pathological study, and then you can know, okay, whether it is carcinoma or not, right? How's it going, people? Too much? So based on what you see, whether the what size the tumor is, okay, based on centimeter size of the tumor, or if the lymph nodes are involved, so you will do the TNM staging, where M is metastasis, right? So let us go ulta here. There are 4 stages here. So this is 4th stage here. 4th stage here, what are they saying? When there is metastasis, they are making it as 4th stage. Simple. Okay. Guys, the staging really did it help you, and it is very confusing when you learn with other cancers, right? So just remember there is stage 1, 2, 3 and 4. Okay, 4 is where there is metastasis. Okay, and you remember 4 stages of cancer. Okay, lung cancer. You have you're doing some kind of oncology. I don't think you need to know very specifically each of this. Okay, now coming to SCLC, that is small cell lung cancer. This has 2 things. You have to say that it is limited disease or extensive disease. And unfortunately, the extensive disease itself is more, right? So limited disease is small number of cases. That is why they say this small cell lung cancer is very aggressive. Okay. So what and all you have in small cell lung cancer, you have 2 more varieties. I mean, you can do the staging, and also you can say limited or extensive. Very good, guys. So then let's move on. We are done with investigation, right? So we are done with staging now. Now let us go to the last part of this bronchogenic carcinoma. What have they asked in the exam? Okay, so we finished the causes, the clinical features in which we have covered the types, right? Types of bronchogenic carcinoma. Investigations we have finished. Now let us go to the last part, that is treatment. Okay. So what treatment will you give if it is bronchogenic carcinoma? Think about lung cancer. What treatment will you give? So if there's lung here and there is cancer here, okay. So this cancer either here or somewhere. What treatment will you give? See, you can do some kind of surgery if it is non-small cell. They are saying small cell. They are not talking about cancer because it's very fast spreading. So you can talk about some cancer treatments and surgery. Okay. Let's get started. Okay, so you will have multidisciplinary teams involved in this. So you will have oncologists, thoracic surgeons, respiratory physicians, and nurses, specialist nurses. Okay. So if there is pleural effusion, which is malignant, when malignant pleural effusion is present, then you should drain the pleural cavity using intercostal drain. Guys, focus here. Depending on the how the person responds, you can do subsequent fluid drainage. Okay, you can leave some indwelling pleural catheters or pleural diuresis with sclerosing agents such as talc. Wow, first time I'm hearing talc actually. Talc as a treatment for removing that effusion. Okay, then you have so what and all this spoke about here. Pleural effusion, if it is there, you do some drain. Okay, and then you can leave some catheter inside, indwelling catheter, or you can use some sclerosing agents such as talc. Okay, this is for pleural effusion. Okay, then other things what they're saying: surgery, radiotherapy, chemotherapy, laser therapy, and stenting. See, till now you always heard of radiotherapy, chemotherapy, right? Surgical also we have heard of, where we'll remove the part of lobe, etc. Laser therapy is something that is new, written in Davidson textbook. So focus on this: laser therapy and stenting. Okay. So let's look at the treatment in detail now. So here we have written surgical you will not use for non-small cell lung cancer. This is very important, okay, because that is aggressive and you will not do surgery for that. So if it is non-small cell, then you will do surgery. That much you have understood. Now let us go to radiotherapy quickly. So they are saying radiotherapy, if there is obstruction, they like radiotherapy. Obstruction. Okay, if there's obstruction, they're saying radiotherapy will be good. And they're saying combine it with chemotherapy. Okay. And especially for small cell lung cancer, what will you give? You won't give surgery, so you will give radiotherapy, chemotherapy. Okay. You can prevent the development of brain metastasis, etc., by doing all this. Okay, that's what they are trying to say. Now we are done with some understanding of surgery. Okay, and radiotherapy. Now let's move to chemotherapy. Chemotherapy is where you have to write the drugs, right? This much you understand, because chemotherapy is chemical. That means you will give some cytotoxic drugs. For non-small cell lung cancer, you write these names, okay? Tyrosine kinase inhibitors, erlotinib, okay? Erlotinib, you write erlotinib, tyrosine kinase inhibitors, if you can remember, erlotinib. Then you write bevacizumab, that is monoclonal antibody. For some people, you have to check whether this gene is there or something like that, epidermal growth factor receptor gene. Then only you can decide the treatment, okay? So what will you write here? Erlotinib, sorry, erlotinib. Oh god, let's try to remember it. Let's write it and remember it. Wait, erlotinib. It is a treatment, so we'll write in green. Tyrosine kinase inhibitors, erlotinib. Okay, erlotinib. Then monoclonal antibody, that is MAB. So that is nothing but bevacizumab. For this you have to check what? EGFR gene you should check. That is epidermal growth factor receptor. Okay, then only you will give some treatments. Okay, erlotinib, bevacizumab. Please try to remember these two names, guys. I know. Take a deep breath. We'll go to the next names. So guys, standard side effects of chemotherapy, nausea, vomiting, etc. you write, okay? Then coming to the small cell lung cancer, they're talking about radiation. We already told you radiotherapy with chemotherapy. For limited stage, they're talking about cisplatin etoposide, and for extensive stage, same cisplatin etoposide with some other things like carboplatin, atezolizumab and durvalumab. Wow, what names. Okay, so remember it's a combination of chemotherapy and radiotherapy. Cisplatin etoposide, at least you can remember these are common. Cisplatin etoposide. Okay, now I'm just going back to the treatment here, guys. The last thing what you saw was laser therapy and stenting, right? So basically for obstruction, again they're talking about all this. Okay, if there's obstruction, they're talking about all this. So they are saying that it will also allow re-aeration of collapsed lung or something like this. Okay. Clear the tumor tissue and allow re-aeration of collapsed lung. Okay. Especially if it is main bronchi, then they are saying this will work. Okay. So they are talking about endobrachial stent. They are saying better for tumors of main bronchi. Okay. If there is compression by nodes, if there's obstruction, then what will you give, guys? One of the things that they are saying here is laser therapy with stenting. Okay, endobrachial stenting for major bronchi, this will work, they are saying. Okay, then you remove the tumor tissue also, they are saying, then you can re-aerate the collapsed lung, etc., etc. You got it right? One thing they're telling is that, guys, after doing so much also, the survival rate is not that great with lung cancer. Okay, best outcomes are managed with specialists. So you have to give them antidepressant, you have to give them pleural effusion drains, etc., etc. You understood, right? Okay. What's new in lung cancer? Some sublobar resection, that means surgical removal, right? You're going to remove a very small part of the lung. You understood? Sublobar resection. Okay. Sublobar resection. This should be green because this is a treatment. Sublobar resection. Okay. Then sublobar resection. Sublobar resection. Okay. So now we have completed the treatment also. So multidisciplinary, you need people, pleural effusion, you will drain, put some indwelling catheter, sclerosing agents such as talc. Sclerosing agents such as talc, I told you, right? Then surgical sublobar resection, but not for small cell lung cancer. Radiotherapy if there's obstruction. Chemotherapy, what and all names you have to write. For non-small cell lung cancer, you will first check that gene, epidermal growth factor, EGFR gene, and then what will you give? Tyrosine kinase inhibitors like erlotinib, and then monoclonal antibodies like bevacizumab. Okay. Then if it is small cell lung cancer, what chemotherapy will you give? Cisplatin and etoposide with radiation, right? Let's just confirm that. Correct. Okay, cisplatin, etoposide, radiation are common for these two, but if it is limited, if it's extensive, you have to add this atezolizumab, if you can remember. Okay. Then what are the side effects of all this? Nausea, vomiting, etc. Then coming to laser therapy and stenting, if there is obstruction, to remove tumor tissue and to re-aerate the collapsed lung, especially for major bronchi, endobronchial stent. Wow. So we finished bronchogenic. Carcinoma, guys, that is lung cancer, asked for 10 marks. So you should know everything that is there that we discussed. Now, why are they asking this? I told you, because this lung cancer is increasing, especially in women, it's increasing and it's becoming a leading cause of death. Bye-bye.